Hello, I'm Jasmin. Today I will be presenting my case study. My patient was a 77-year-old female. I got to work with her the week of February 15th and February 23rd. Patient came in with chief complaints of weakness, confusion, and dyspnea. Doctors admitted her with a diagnosis of atrial fibrillation with rapid ventricular response. This is when rapid contractions of the atria make the ventricles beat too quickly. Some background on this patient. She was discharged from the hospital on 2/11. Patient came in for a GI bleed and had a colonoscopy. During the stay, she was shoulder shrugging, pursed lip breathing, and in the tripod position. She was also using her accessory muscles to breathe. During the stay, we were told to get an ABG on her, but because she looked like she was in respiratory distress, we went ahead and got an airvo to kind of help her with that air hunger while we got the results back on her ABGs. By the time that we got the airvo, her ABG results came back abnormal to where we went ahead and skipped the airvo and got the BiPAP machine. She was on the BiPAP for a few days, but was doing better and was put on a nasal cannula and sent home on 2 liters. On February 14th, 2 days after she was discharged, she came to the ED with altered state of mind, shortness of breath, and right-sided weakness. Her workup revealed that she was in AFib with RVR. She was given some antihypertensive medication. They also found that she had an acute lower extremity DVT. There was concern for a suspected PE, but VQ scans were considered undetermined. Echocardiogram did not show right ventricular strain. She did have a left frontal parietal acute ischemic stroke that manifested to right upper limb weakness and aphasia. She also had left-sided carotid stenosis, which no surgical intervention was sought out for. Cardiac diagnosed her with a type 2 non-STEMI, which means that she could have had a heart attack, so initially she was just clotting everywhere throughout her body. Patient then developed bradycardia and her antihypertensives were stopped. Patient also started to decrease respiratory-wise, and she went from 2 liters to 6 liters to then being put on a BiPAP. At this point, her principal problem was then updated to acute on chronic respiratory failure with hypoxia and hypercapnia. So some of the patient's history, she does have COPD. She was a previous smoker, 45 pack years. We didn't really get a chance to ask what she did for a living, but in her chart it was stated that she was retired. She had a history of acute DVTs. She also had a CVA, which is cerebral vascular accident, which is another way of saying that she had a stroke. She also had pulmonary hypertension, usually affects the arteries in the lungs and the right side of the heart, as well as acute kidney injury. She also had elevated troponin, which is a big indicator of heart attack. We also have acute metabolic encephalopathy. Usually this happens with having other health conditions such as diabetes, liver disease, kidney failure, or heart failure. These diseases really make it hard for your brain to work properly. She also had chronic anticoagulation, so she was just on anticoagulants to prevent these clots. She had a carotid endarterectomy, which is a surgical heart procedure, and she had stage 3A kidney disease. This is a mid-stage of kidney disease. Stage 3 is not reversible, but you don't need dialysis at this point. When assessing this patient, both weeks she did have normal skin color. We didn't notice any blue fingernails or anything like that. Her skin temperature was fairly normal. She was lethargic both weeks, and she did use accessory muscles to breathe. She was not diaphoretic. Her breathing patterns were irregular but still symmetrical, and we did not see any edema. So I have some vital signs from both weeks. On the left side, we are going to have the vital signs that were taken on 2/15. Her heart rate was about 60. Her respiration was 24. Her SpO2 was 95 at between 65 and 75% FiO2. Her blood pressure was elevated and it was 132/98. Her temperature was normal. Her eyes and nose kind of show that she was not voiding much, and her lung sounds were coarse with rhonchi. This was the first time that I actually got to experience what rhonchi feels like, and every single time the patient took a breath in and a breath out, you could just hear her chest just moving from all the secretions inside. Vital signs for the second week, February 23rd. Her heart rate was elevated at 136. During this time, both nursing and respiratory were in there trying to make sure that she wasn't desatting, but if she wasn't desatting, she was having really high heart rates, or she was having low blood pressures, or it was the opposite to where she was having really high blood pressures. Really, she was one extreme to the next. So it was really complicated to keep this patient on a good level when it came to her heart and when it came to her lungs. Her respiration rate was 29. SpO2 was about a 94 during this time at 70 to 85% FiO2. As you could see, we definitely increased it from the previous week, and we just kind of kept increasing it from there. Her blood pressures, again, kind of either really high or they were dipping really low. Overall, her temperature was kept fairly normal. Her eyes and nose got a little bit better. And then her lung sounds for this week, they really sounded diminished on the lower lobes, and you could hear audible wheezes when she exhaled. You could still hear some rhonchi, but it wasn't too bad. So for the alterations, I kind of put some stuff here that kind of go hand in hand with the alterations. In Jardins on page 287, it did say when a person has a stroke, they could have a silent aspiration. Basically what this means is that the person will aspirate, but you won't get to see the coughing or anything that indicates any aspiration is happening. In Jardins on page 280, it did say that this patient was at risk for pneumonia just for having that COPD, diabetes, stroke, being over 65. And also looking at the fact that she had a DVT and a suspected PE, which they basically treated her as if she did have one. Based off Jardins on page 321, they listed some signs which really make you think that this person did have a PE, but some signs are AFib, tachycardia, lightheadedness, wheezing, cough, and shortness of breath. So for alterations, we're going to see atelectasis. So the patient did have some pneumonia, so we're probably going to see some consolidation in there. Because of the DVT and the PE, in Jardins on page 321, it says that with DVTs and PEs, we could likely see a patient with bronchospasms. We will also see some inflammation, which really makes gas exchange a little bit harder. So we're going to be seeing that increased AC membrane thickening. Based off her lung sounds, we definitely see that she had an increased bronchial secretions. With her COPD, we'll see chronic distal airway and ovular weakening. And again, with her DVT and PE and just her heart condition, we're going to see some perfusion problems. And also from her heart conditions, we're probably going to see some increased fluid in the pleural space. So here I have some lab results. We can see that her white blood count was elevated. The first week it was 25.9. The second week it was 24.49, which is still elevated. Her red blood count was low, which it could be kind of expected just because she did have a GI bleed previously. So it was 3.24 that first week, and that second week it just kept decreasing to 2.74. Her hemoglobin was at a 9.2, which is low, and it just kept decreasing that second week from 9.2 to 7.6. Her hematocrit was 29.9, which is low, and it just kept decreasing to 23.4. Her sodium levels that first week, they were normal, but then they just increased to 152 that second week. Her potassium kept normal throughout her stay. Her chloride levels, they were normal that first week, but again, they increased that second week. Usually with sodium and chloride increasing, it could mean that the patient is experiencing some dehydration. It could also be some signs of kidney disease, which she does have, and it could lead to a metabolic acidosis, ABG. Her BUN level was elevated that first week, and it went from 48 to 77 that week. Usually BUN means that the kidneys are not working well, and again, it could mean dehydration. Creatinine was 1.92, which is high, and it kept increasing to 2.21. And again, this just kind of means that she has poor kidney functions. There was no albumin the first week, but that second week, they did get levels of 3.1, which is considered low. Having low albumin could mean that the body is just not getting enough nutrients that it needs. Her glucose was 133 her first week, which is high, and it kept increasing that next week to 252. Glucose can sometimes increase just from infection. Her platelets were fairly normal, but as you can see, that second week they started to decline. Her PCT was high, and this is an indicator of sepsis. We did try to get a sputum sample with this patient, but we couldn't. The patient became agitated as soon as we tried to get that sample. So this is an ABG that was taken after they initiated BiPAP on the 15th. So when looking at this ABG, if this was a normal person, you would probably fix this by increasing IPAP to kind of get that PaCO2 down. Because this is not a normal person and she does have COPD, this could be a normal reading for her ABGs. So some of the things that they did for this patient was put her on BiPAP, and they put her on higher settings than the regular 10/5. So they started off with 18/12 at a rate of 12 with FiO2 at 40%, which as you can see, she was later increased. So this is not a chest x-ray of the patient that I had, but I did choose one that kind of had some atelectasis on the right side because I did kind of see this on her x-ray. On 215, the doctor interpretation was infiltrative density in lower lungs with small pleural effusions, which are stable. Pulmonary vascularity is normal. Atelectasis versus consolidation. On the 22nd, the doctor interpretation said interval increase in mid to lower right lung infiltrates with small effusion, new or increasing, medial left bacillar atelectasis with some infiltrates, mildly increase. Heart size was stable and no acute pulmonary edema. So on this patient's x-ray, you could definitely see the blunted intercostal angles. In Egan's on page 429, it says that pleural effusions usually are bilateral. Also on her x-ray, you could see that her lungs looked a little bit bigger for her body. Egan's on page 436 says that this is associated with people with COPD. You're going to see some hyperinflation. And just to remind you guys, this patient was 5'6", and she only weighed 114 pounds. She was also getting some tube feedings through her nose, so she wasn't eating normal food. So these are some medications that the patient was on. The first one was Lipitor. This is usually to treat high cholesterol levels. It may reduce chest pain, could reduce stroke, heart attack, heart and blood vessel problems. This patient was also on some aspirin, which is a non-steroid anti-inflammatory and blood thinner. Retacrit is to treat severe anemia, causes bone marrow to make more red blood cells. Sumedrol, it's used to treat inflammation caused by asthma, blood bone marrow problems, may lower the risk of death after a heart attack. Lopressor is a beta blocker for high blood pressure and heart failure. Diltiazem is to treat high blood pressure again. Heparin, just to prevent blood clots. For her respiratory meds, this patient was on Brovana, Pulmicort, Xopenex, and Yupelri. So they had this patient on Brovana, which is most likely just to kind of help with that COPD. Also, she was on Pulmicort, which is that steroid that's going to help facilitate breathing with that chest tightness, the wheezing, and the coughing. And then she was also on Xopenex, could be a rescue inhaler. She did take that 3 times a day. If you heard her lung sounds after her nebulizers, the wheezing really did subside. And it also helps with shortness of breath from COPD. And that Yupelri is just to kind of treat her COPD as well. So we're at the part where we have to ask ourselves, is therapy working? Her SpO2 level, we did try to keep in that normal range with that FiO2. Her work of breathing, that was also better. She was still using her accessory muscles to breathe though. Her lung sounds did sound better throughout the day after her nebulizer treatments. And we did still hear some coarse sounds from her lungs. In that first week, we could also still hear and feel that rhonchi just from all of those secretions. For the second week, we could see that her atelectasis hadn't gotten too much worse. Her work of breathing was about the same, still using those accessory muscles, and we did have to go up on her FiO2. Her lung sounds, you could barely hear any rhonchi. But she had developed some wheezing. I don't know if it was just more apparent to me and she just had that wheezing throughout, or if she just developed it. Her lungs did not sound as coarse as before. She was still very diminished towards the bottom lobes. So what are some suggestions to improve patient condition? So one of the things that we could have done that first week is suction. It was something that we really wanted to do, and if the patient wasn't as agitated, we could have definitely seen probably better gas exchange. She could have been breathing a little bit better. She could have needed a little less FiO2, so suctioning could have really helped this patient that first week. Shorter and longer times off BiPAP. That first week, she could be off the BiPAP for 30 minutes, be completely fine, and be on the Airvo. During that second week, she could be off the BiPAP for about 5 minutes and then quickly dip into the mid 80s, and we would have to get her back on the IPAP just because she couldn't sustain herself on the Airvo as long anymore. Another thing that we could do is titrate her BiPAP settings. Obviously, this patient, we did do that with her FiO2. We also did have to titrate her BiPAP settings with IPAP and EPAP towards the end. But if the patient was feeling better, we could also titrate those settings down and maybe go on the Airvo and then maybe on a nasal cannula again. So for sure, continuing her respiratory meds is very important. They really seem to really help her, especially her lung sounds right afterwards. They sound so much better. And then also titrating that FiO2. Unfortunately, we ended up titrating her up. We couldn't get her down. Keeping the patient very comfortable. When we did put her on BiPAP, we made sure that the mask fit nicely on her face. We made sure to put some padding on her nose so she didn't get any lesions on her face. Made sure to go ahead and swab her every now and then to make sure that her mouth was not too dry. And then, of course, taking her off the BiPAP as long as we could. We know that sometimes BiPAP isn't the most comfortable thing for a patient. So getting her off the BiPAP, even if it was for 5 minutes, we could see that she really liked that. So patient outcome. This was the patient's BiPAP settings. It was 22/12 at a rate of 16 at 100% FiO2. From this week to last, you can see that her labs showed that her white blood count hadn't gotten any better. At this point, doctors concluded that the patient was septic on February 15th. Also, with all of her abnormal labs, you can also see why her body was having a hard time clearing that pneumonia. So if we were to talk about short-term outcomes that first week, we could have said that the patient would be awaiting medical stability to work with PT/OT to get into a skilled rehab, possibly go home. For long-term care, the patient would have had to have rehab because of that stroke. So just learning how to do basic things. Patient would maybe have to have had some changes to her dietary needs just to avoid those aspirations. So outcomes for this second week, cardiologists had given her an overall poor prognosis. Due to her heart disease, she had mild aortic valve regurgitation, mild mitral valve regurgitation, moderate tricuspid regurgitation. The family was talked to and they understood that there was no more that the hospital could do for the patient. On day 11, the patient's respiratory status declined. We had to raise her FiO2 to 100%. Later on that day, her saturations were not being met. At 100%, she was at 81%, then dipping down to the 70s. The patient passed away on 2/24, with her end diagnosis being acute on chronic hypoxemia with hypercapnia, respiratory failure, acute on chronic, congestive heart failure, acute on chronic kidney disease, AFib with tachycardia, hypertension, COPD with remote tobacco use.